back. So this next session is kind of a random one. Congenital esophageal stenosis, not a very common topic like appendicitis. But we're talking about it because this was something that was published, and the authors here joining us from Turkey, that surprised a lot of us because there's always a question about, do you resect these or do you dilate these? What do you do with congenital esophageal stenosis? So with us, we have Dr. Ajay Kaul, we have Dr. Kilic from Turkey, and Dr. Dan von Allmen. Aaron couldn't be with us today. So Ajay, can you hear me? Ajay? Looks like they can't hear us.
Yes. Thanks, everybody. I hope you can see my screen.
Yes, go ahead.
All right, so this is a case study we're going to present in the beginning, and then we'll have a video from Dr. Kilic on the topic, followed by some rebuttal. So we have a 24-year-old male who has been vomiting since he was 9 months of age, presented to us when he was 2 years old. It was noted during transition to solid foods for the first time, and he vomits undigested food soon after eating. There's no history of drooling, no choking, no coughing, and he's had no weight loss. He's thriving. He does not have any comorbidities. They did a fluoroscopy at the outside hospital, and the diagnosis was achalasia. He had an endoscopy performed at the outside hospital. They noted a tight lower esophageal sphincter and an esophagus full of retained fluid. They referred the child to us with the diagnosis of achalasia. When we first saw the patient, the parents had the confirmed quote unquote diagnosis of achalasia and wanted a Heller myotomy and did not want any dilation at all. So this is his fluoroscopy. As you can see, picture on the left showing a dilated esophagus. On the right, you see the narrowing in the lower esophagus, opening into the stomach. And the audience poll now is, what would you do next? High resolution esophageal manometry, endoscopic ultrasound with biopsy and a Cree balloon dilation, endoscopy with biopsy and a pneumatic balloon dilation, endoscopy with FLIP or functional lumen imaging probe, schedule the child for Heller myotomy with partial fundo, schedule the child for resection of the stenotic part without fundo.
There you go. Already see how surgeons usually can never get more than 4 choices, but we got now a lot more. So what are people's thoughts? What do you do in this patient? You've got that narrowing. Any thoughts back here? Anyone? What would you do?
I'm sorry, I can't hear the speaker.
You can't hear me? He can't hear me.
No, barely.
We turn me up a little bit? All right. No one has a thought. Everyone's a little worried because they don't want to say the wrong answer. What are you confused about? So you've got this long, smooth narrowing at the end of the esophagus. What do you do? It looks like a congenital.
And has only had fluoroscopy so far, no other imaging. There was an EGD.
All right. I don't know if Jay can hear us or not.
No, I can just barely hear you, Dan.
Here for people's thoughts on what they would do with this case. And there are a lot of people looking down and looking at their phones and looking away and avoiding the answer. So I think that this is a perfect discussion to have. And I'll tell you, I'm old, and my answer would have been that you have to resect. First, I would do a diagnostic approach, and I think that there are some new diagnostic techniques we have now that we never had access to before, thanks to you, Ajay. But that if it is a congenital esophageal stricture and you prove that the only treatment for that is to do a segmental resection.
That's great, Dan. And that was one of the intentions of having this talk, was to kind of highlight the newer technologies that have come about over the past decade or so. So what we did was a high resolution esophageal impedance manometry study. And what you're seeing here is a pressure study of the esophagus and the pharynx. What you see here in the top of I don't know if you can see my arrow.
Yes, we can.
So that's the pharynx, and the warmer colors are higher pressures, and the lighter colors like blue is low pressure. So what you're seeing here are several swallows, and you see the upper esophageal sphincter relaxing to allow the bolus to go down. And then you do not see any peristaltic contractions in the body of the esophagus, which means that it's an aperistaltic esophagus, which you typically see in patients with achalasia. The second feature of achalasia is when you look at the lower esophageal sphincter, that should not be relaxing the way it is here. So there's one feature of achalasia here, but the other feature is not consistent with achalasia. So you're really not getting a definitive diagnosis on this high resolution manometry. The software is giving us a diagnosis of EGJ outflow obstruction. If you look at the metrics I've highlighted down at the bottom, the IRP at 4 seconds is 37, which is very high. IRP is the integrated relaxation pressure of the lower esophageal sphincter, which is consistent with the diagnosis of achalasia. And peristaltic integrity is failed, which is also consistent with achalasia. So at this stage, we were kind of not sure about the diagnosis of achalasia. So the next study we did was, let's do the endoscopy. And during the endoscopy, we did intrafluoroscopy, and we also did endoflip, which is another new technology, and I'll go into that in a second. So in the endoscopy, what we see here, and Dr. Kilic can give his comments on what he feels the mucosa looks like, but this does not look like a normal mucosa. There's definitely, it's paler than normal, quote unquote, could be potentially fibrotic. And then when you put the scope down and in the distal esophagus, you inject the contrast, you see the contrast flowing in this thin kind of a lumen down into the stomach. This is remember, this isn't with force that we are pushing the contrast. This is not the patient drinking. We're really injecting it at high force into the distal esophagus. So with this, we then did the endoflip, which is also a catheter-based test done while the patient was under anesthesia. And at 40 ml distension of the volume of the balloon, the pressures were high, the diameter was not that bad, and the distensibility of the lower esophageal sphincter was in the area of achalasia again. But what was interesting on the endoflip was that we were seeing some retrograde contractions, as you can see here, 4 retrograde contractions going backwards. But we also saw a secondary peristalsis going down the esophagus. So some folks would say if you have that, you categorically rule out achalasia, that this is not achalasia. But if you look at the lower esophageal tone, it's high, and it's not relaxing as the contraction is going. So we're getting a very mixed picture of is this truly achalasia or not. The child got a CT angiography. I'm not sure why the angiography was needed, but essentially they remark on the marked diffuse circumferential thickening of the esophagus with mild gaseous distension of the lumen. So the next audience poll is, what would you do next? Would you do you're not sure of the diagnosis right now. Do you do the EGD with Cree balloon dilation? Do you do EGD with pneumatic balloon dilation, which you typically do in a case of achalasia? Do you do surgical resection with partial wrap, or do you do a surgical resection with no wrap?
Hey, Ajay, well, people are answering that question. What about endoluminal ultrasound?
So that's the next test. I was going to bring that up when we discussed Dr. Kilic's study at the end. But yes, you could certainly do the endoscopic ultrasound instead of the CT scan, because that would show you the wall of the esophagus and the thickening that you saw on the CT. So that would be a much easier thing to do, endoscopic ultrasound, because you're doing the endoscopy anyways, and you can do all 3 at the same time, meaning you can do the endoscopy, you can do the endoflip, you can do the intrafluoroscopy, and you can do the ultrasound at the same time, all under one anesthesia.
All right, let's see what the poll results look like.
It was 35% on the manometry side.
It's about split EGD with pneumatic balloon dilation or C or D. I don't know, it's pretty split evenly.
It's all over the place. So far, with this, I send it GI. You'll figure out if they need surgery or not. This is where I'm at in my head. All right. So let's show those, and we're like running about 15 minutes behind. So let's quickly show that, and then we'll go to play the video. So Ajay, did you have a comment to make, or should we roll the video? Is that the next step? All right, let's go to the next slide. Go ahead.
It was sort of, the answers were all over the place. It was basically one of each. So the
Well,
question,
understandably so, and the whole intention of this talk. So yes, so we have all this new technologies, and we're trying to figure out, is this a really low congenital esophageal sphincter mimicking as achalasia? Right. So I'm going to show Dr. Kilic's study now. I hope I'm able to run this.
Hi everyone. First of all, I would like to thank you for including me in this important meeting and for your interest in my article. Today, I will share my article in which we describe the approach we apply in the treatment of congenital esophageal strictures in our center. Our study was conducted in a tertiary center. The results of a single surgeon operating for the treatment of congenital esophageal stricture were evaluated retrospectively. In the treatment, a step-by-step approach was applied from non-aggressive balloon dilatation to surgery. We had 19 patients in our study, and 11 of them had esophageal atresia and tracheoesophageal fistula. The prevalence of congenital esophageal stenosis among esophageal atresia patients in our clinic was 88.3%. For diagnosis, esophagography was first applied to all patients. 24-hour pH monitoring was performed in patients requiring differential diagnosis with gastroesophageal reflux. Esophagoscopy was applied to all patients to be used during diagnosis and treatment. For treatment purposes, we first applied balloon dilatation in the esophagus. After placing the balloon in the stenosis area of the patients, the balloon pressure was increased to 3 atm and we waited for 3 minutes. If there is a dilation of the stenosis on fluoroscopy, the balloon pressure was increased to 5 atm and we waited for another 3 minutes. Then the dilation was terminated. However, when there is no dilation in the stenosis area by waiting for 3 minutes, after the pressure increased to 3 atm for the first try, the dilation is terminated and the attempt is considered as failed. The patient's clinical condition, symptoms, and response to the stenosis to dilation were taken into account in determining the next dilation time. Esophageal dilation was performed most frequently every 2 weeks and a median of 5 times. No complications developed in any patient. After the esophageal dilation, 14 patients were completely asymptomatic. Intermittent swallowing difficulties persisted in 2 patients, and 3 patients did not benefit from dilation. Surgical treatment was also applied to these patients. We evaluated the following data when deciding on surgical treatment: the patient unresponsiveness to dilation, the presence of uncontrollable aspiration, the presence of frequent recurrent pneumonia, the inability to tolerate oral feeding, and the presence of continued growth retardation despite dilation. Since all the patients with a stenosis in the esophagus are in the distal esophagus, and we thought that gastroesophageal reflux may develop after the esophageal stenosis is removed in these patients, we decided to perform anti-reflux surgery in the same session. For this reason, we prefer transabdominal surgery. We also took care to protect gastroesophageal junctions in these patients. We performed cholecystopy surgery on 1 patient and cholecystectomy surgery on 2 patients. When we evaluate surgical treatment results, an anastomotic leakage developed in 1 patient and he was followed conservatively and recovered. In 1 patient, stenosis developed in the anastomotic line and the stenosis disappeared after dilation twice. The histopathology of the removed esophageal tissue was reported as tracheobronchial remnant in 1 patient and fibromuscular stenosis in 2 patients. As a result, 3 patients who underwent surgery became asymptomatic. Let's talk about the follow-ups. The patients were followed for a median of 48 months, and symptom-free status was achieved in 17 of the 19 patients. 2 patients have intermittent swallowing difficulties that do not affect their daily lives. 14 patients became asymptomatic with only esophageal dilation. As a result, we think that even if a minimal clinical improvement is achieved, esophageal dilation should be insisted on. Successful results can be obtained with esophageal dilation independent of histopathological type, and the surgical approach should be the second line of treatment. Thank you.
So step one, we're going to have to rule out achalasia. The question here is a bit of a different approach in the two different centers. So then the question becomes treatment. So workup and treatment. Dan, comments?
As I said, this I think is a changing paradigm, at least for me. So this will be my practice change coming out of here. But I want to hear the rebuttal to this, or the assessment of this study from Ajay.
So thank you, Dan, and thank you, Dr. Kilic, for sharing your results of your study with us. And clearly, this is one of the larger studies, the largest being from a group from Saudi Arabia, which actually did not 100% agree with the results of this study. But I did have a few questions, and some of them were at the beginning, at the outset of the study, it was not clear as to how many patients of your total of 19 had truly tracheoesophageal remnants with or without cartilage. It was only in the ones that had failed dilation and underwent surgery that biopsy was performed. So is your recommendation that even if there is a cartilaginous element to the congenital esophageal stricture, would you still perform dilation rather than taking him for surgery? So that was my first question. The second question was regarding the role of
Ajay, hold on.
Hold on, Ajay, we're going to translate that. Hold on a second.
We're just going to translate the question for Dr. Kilic.
The question is, just at the end, would you still dilate if there's cartilage?
Selçuk hocam bunu duydunuz mu, çevirmemi istiyorsunuz?
I don't know if we can hear him. We may have to. No, we don't hear him. All right.
So we're having trouble hearing you. So maybe you can text the answer, but we're short on time. So if you could continue, but quickly wrap up, that would be great.
Well, actually, let's just do this. I think, Ajay, if there's does anyone have any final comments, and we can just end the session? Yeah.
Dan,
my biggest concern would always be that we've seen it happen is a perforation.
So, right. So the question, just so you can hear it, is we're just going to cut to the chase here, which is, can you just do dilations with a cartilaginous remnant, or would you risk rupturing the esophagus? Tearing it.
is that Dr. Kilic's question, or?
No, we're just trying to sort of wrap up the session here with the take-home message. Whit, you had a comment?
So my question is that many of these children have esophageal atresia. So the question is, if you have to do an operation, is there concern about doing a Nissen, a callus Nissen in these patients with the dismodal esophagus due to esophageal atresia?
So the question is about the association with esophageal atresia, and does that limit the surgical options because of doing a Nissen in a patient with esophageal atresia repair? Is that what you were saying? Yeah. So I think for us would be great is just to get a take home. What's the take home in terms of these? It sounds like we have new techniques to make the diagnosis, which will be really important. And then, should we dilate or should we operate? That's the question. Do you have a good answer for us, or any answer?
Well, I personally don't have any experience doing pneumatic balloon dilations on these patients, and that was one of the reasons I wanted to ask the folks, do you ever do a pneumatic balloon dilation versus a Cree balloon dilation? And obviously the pneumatic you would put, if there's a cartilaginous element that you're putting the patient at a higher risk for perforation. But you can do Cree balloon dilations, but then do you really see that improvement if there's a cartilaginous element in there?
Yeah. All right, I think we're gonna, go ahead, you have a question? Cree dilator. What is a Cree dilator? I nodded my head and pretended I knew. But.
What's a Cree dilator versus a balloon dilator?
So they're both balloon dilations. The Cree balloon is a softer balloon. The pneumatic balloon dilation is what we typically do for achalasias. It is much stronger and a much bigger balloon. So you're essentially stretching and literally breaking the circular muscles around the LES versus the softer balloon, which is the Cree balloon.
All right.
So I wasn't clear in Dr. Kilic's study, was this Cree balloon he used or pneumatic?
I don't think we're going to get that answer.
I think let's give Dr. Kilic.
Beni duyabiliyor musun?
Yes. Duyuyoruz.
Her durumda öncelikle dilatasyonu tercih edeceğiz. Çünkü daha öncesinde trakeobronşal artık olup olmadığını zaten kestiremiyoruz.
He says, first of all, we need to try dilation because we cannot say if there's an tracheobronchial remnant or not.
Okay.
Devam edebilirsiniz.
Şu anda çok kesik kesik geldiği için bir şey diyemiyorum. Onun da sırası oldu.
Dr. Kaul, credilation ya da pneumodilation yapıp yapmadığınızı sordu. Siz hangisini kullandınız?
Sadece balon dilatasyon.
He just used balloon dilation.
Okay.
So to summarize, this is a new thing for us, as we talked about. I've always resected. It sounds like each hospital is still doing their own thing. But the point is, these don't all have to go to surgery. You'll have your algorithm of looking if there's cartilage or not. Doing some dilation may be safe. We're going to figure this out as time goes on, but I know that it's completely changed my approach because, as Dan said, I've resected all of them. All right.
I think we have a much better way to make the diagnosis, much better technology to be more accurate with the diagnosis, and that will then drive the appropriate therapy.
Much better point, exactly. So, all right, we are going to take a lunch break, and then we're going to come back for the second half of the event. So thank you, everyone.